Okay, check, check.
Good morning. Welcome to Grand Rounds. Really glad that you are here. It is top of the Grand Rounds hour, and I understand that there are over 25 people on Zoom, so we're really glad that you are here. A few announcements before I have the privilege of introducing our speaker for today. Next Grand Rounds is Zach Clayton. Very excited to hear that on December 5th, so that will be after the Thanksgiving holiday. Next Journal Club says February, but probably December. Kate, December? Excellent, December. We will be here for December Journal Club on Zoom. Casey Johnson. Nope, I think that's not correct. So we'll see who the presenters are. Evaluations will be circulated and also posted. Also, all Grand Rounds recordings are available on our YouTube channel through the Multidisciplinary Center on Aging. And without further ado, really excited to introduce Dr. Bettcher, a close friend and collaborator. She's associate professor in the Department of Neurology and a board-certified neuropsychologist. She directs neuropsychology research here at University of Colorado in the Alzheimer's and Cognition Center and directs her lab, the Colorado Aging Brain Laboratory. Her research program focuses on modifiable risk factors for cognitive decline across the lifespan uses cognitive neuroscience assessments and biofluid-based markers of immune dysfunction and Alzheimer's disease pathology to better understand what puts typical aging adults at risk for Alzheimer's disease. She also oversees a longitudinal study of aging and mild cognitive impairment called BioAD, and has several NIH, NIA-funded studies, including a study on teleneuropsychology in the assessment of Alzheimer's disease-related cognitive decline. So I think this is such a timely talk. We have thought a lot about this from a research perspective, and we're really interested in thinking about it in the clinical setting and also the clinical research setting. So thank you for joining us today.
All right, good morning, everyone. Thank you so much for having me. I know that I know a lot of you and have had the pleasure to collaborate with some of you on research projects. So thank you for having me today to talk about biomarkers. I know that this is a topic that is controversial and sometimes not well understood and certainly not always well implemented across disciplines. And so my goal today was really to give you an overview of kind of where we've come in the field from the lens of diagnosis of Alzheimer's disease, how it's changed, what the controversies are, and how I foresee this impacting multiple fields over the next few years. So I'm a neuropsychologist, so I like to make sure that we're all oriented and I appreciate the emotion in the room. And so this may feel like a journey that may feel stressful at times, but I hope by the end of it that you're aware of what's more future-oriented concern and what's happening right now and what things we kind of need to build towards. All right, so I wanted to start with some patient presentations. These are two patients who both have Alzheimer's disease, but have very unique presentations from each other. So the first one I want to go through is a more common presentation of Alzheimer's disease that I would see in my clinic. So from my perspective as a neuropsychologist. So I saw a 78-year-old gentleman who had multiple vascular risk factors, so hypertension, hypercholesterolemia, obstructive sleep apnea, came in with a 2-year history of attention difficulties. This is a very highly educated gentleman who had a PhD. Current diagnosis was thought to be vascular with a severity level of mild cognitive impairment. When he saw me, he did very poorly on memory testing, showing what we call rapid forgetting. So very quickly forgetting information on these formal, more challenging memory tests. Also had some difficulties with planning and organization. Social skills were amazing. So very socially, interpersonally preserved, definitely a strength. His family, who had not been to any of the other healthcare appointments, so had not been to primary care appointments, reported that he had been the victim of a financial scam, had been in 2 car accidents, and occasionally was forgetting to close the front door. And then biomarkers revealed Alzheimer's disease with a likely etiology of his presentation. The diagnosis was then made of AD with co-pathology of vascular disease, likely mild dementia level of severity, given that the family was now needing to intervene in more daily activities. So I bring this, and sorry, I see that it's advanced a little bit there, but I bring this first patient up because I think that this is a fairly common presentation of multiple vascular risk factors, so some question mark around vascular contributions to their presentation. Someone who's very socially preserved, which I think is often very common in Alzheimer's disease. But upon further testing, seeing that there's often some compensation there that's not always easy to see when you're talking with someone. May not be something that they bring up. They'll often say attention or, not paying attention to something. And again, I also want to reiterate that because I think that this is challenging. This is my specialty. I only work with aging adults in a neuropsychology lens. And I think it is challenging when you have someone come in with multiple risk factors who's not telling you that they have memory problems. So the patient on the right is a very different presentation, also complicated and challenging in terms of diagnosis. So this is a 60-year-old woman who came in with some hypertension, really complaining of 5-year history of vision problems, not reporting any memory difficulties at the time, no current cognitive diagnosis. Her earliest symptoms were that she was having problems with driving, specifically really feeling like she couldn't see the lines that were on the road, and so was kind of moving into the other lane of traffic sometimes, bumping curbs sometimes, but really describing it as difficulties with seeing what was in front of her. With me, she also mentioned that she was having some difficulties calculating some tips, a little bit of math issues there. Very appropriately, she had been sent to optometry, ophthalmology. All of that were negative workups. There was nothing they could see that was wrong with her vision. Her family reported, and for me, this is a case and a presentation that's always really sat with me. This is someone from a few years ago. Her husband reported to me that she'd always handled the finances. He had not been involved, and found out that she'd missed many, many mortgage payments. Over that year, they ultimately lost their home before he was able to take over most aspects of their finances there. On testing with me, she showed really severe difficulties with visual spatial function. So perceiving stimuli in front of her, where things were in space, couldn't copy basic figures. And her brain MRI showed pretty significant atrophy in the posterior part of her brain. Again, we ran biomarkers. Alzheimer's disease was a likely diagnosis. Posterior cortical atrophy was the syndrome that we would call that mild dementia level of severity. So both of these patients, very different demographics, very different ages, very different syndromes, but both had Alzheimer's disease, and I think are both challenging when they come in with these symptoms that are not specifically memory in the initial intake. Okay, so springboarding from that, I think a really important backdrop to understanding how diagnostics have changed with Alzheimer's disease is to think about the terminology, which I find to be painful and confusing terminology. It's always challenging when a syndrome and an etiology have the same name. And in the case of neurodegenerative diseases, it's even more problematic because those syndromes are not always caused by that etiology. And so where this field has moved, and I think probably many fields have moved as well, is trying to separate out syndrome from all these different other facets of the presentation. So when a patient comes in, with cognitive concerns, the collective information that they are giving you really represents that syndrome. That, however, is different many times than the actual performance on their cognitive testing, what their brain structure might look like. Uh, it doesn't exactly tell you always the right severity initially and the etiology. We hope and we are looking for all of those patterns, but they are not synonymous. And so you can have someone who comes in who tells you that they have some attentional problems. They're having a hard time locating things. And then on cognitive testing, have very, very severe memory difficulties. But then you look at a biomarker test and it's not Alzheimer's disease. And so what is it at that point? All of that is then separated from severity, which is, we'll get into in the next slide, but staging of what you see in front of you. And again, all of these terms that are used have been kind of used synonymously in ways that make it even more confusing, I think, to know what's going on. And so again, when I'm talking about syndrome, I'm often talking about with Alzheimer's disease, these memory predominant amnestic presentations, and trying to move fluidly from there of, okay, what do I think the staging is? Is this MCI? Is this mild dementia? What do I think the cause is? Is it Alzheimer's disease? Could this be Lewy body? Could this be vascular? Um, and this is something I'm going to come back to several times, I think, throughout the talk because of the conflating of those terms and how it can, I think, impact how we think about it in terms of conceptualization. So in terms of that severity piece, the evolution of these symptoms over time, I think we're all familiar with many of these terms. I'm going to ask you to initially ignore the preclinical area there, try to suppress that, and I will, I will come back to that at the end. But I think for the rest of it, these are terms that we're used to seeing: mild cognitive impairment, mild dementia, moderate dementia, severe dementia. These are now moving a little bit more towards having that severity term combined with an etiology term. So mild cognitive impairment is mild symptoms. Usually the patient's reporting it. We see a little bit of on testing, but it's not significantly or severely impacting their daily life, which differentiates it from dementia level of severity where you are seeing it impact their daily life. But those are severity terms. They don't tell you the cause. And so you can have MCI due to Parkinson's disease. You can have MCI due to a frontotemporal dementia, due to vascular disease. So it's a severity term. So in general, I think there's a more movement to saying, okay, this is the severity, MCI due to possible Alzheimer's disease, or mild dementia due to possible Alzheimer's disease. And this is also something that comes up with our patients quite a bit too. I'm asked continually, what's the difference between dementia and Alzheimer's disease? And we kind of walk through that dementia is a severity term that could be caused by many things, and we think it's due to Alzheimer's disease in your case. So broadly taking a step back a little bit in terms of risk factors for Alzheimer's disease, I'm sure most of this is familiar, but I'll briefly run through it. I think we all are kind of aware that Alzheimer's disease is the most common cause of dementia in late life. But broadly, cognitive impairment of all types, so all etiologies, for people over the age of 65, about a third of people are impacted by it. This is from a recent study in 2023, looking at combined MCI and dementia rates. And it looked like it was about a third of people over the age of 65 were affected. Again, not necessarily Alzheimer's disease, all etiologies. Most studies have shown that for people with MCI, that about 50% of them end up having Alzheimer's disease. And this is age related. So these estimates increase as we get older. So much, much lower, obviously, in your 60s, much, much higher in your 80s and 90s. Women are at greater risk for Alzheimer's disease. For a long time, the thought was that it was mostly due to longevity. We live longer, and so we get the benefit of getting diseases later in life. And that is not fully explaining that association. It does explain a large piece of it, but it does not explain all of it. And so there's a lot of research going on right now about different contributions based on hormones, differences in immune regulation that might put females more at risk, but females are at higher risk. In general, family history is also considered a risk. That's different than saying a clear genetic cause. Most of Alzheimer's disease is sporadic, and so not a single causative. It's not an autosomal dominant condition. There are some forms of Alzheimer's disease that are, but rare. Rare meaning 1% or less. For people with sporadic Alzheimer's disease, there are genetic risk factors that are not what we would call those causative risk factors. And that's the ApoE gene. And I think we've seen a lot of discussion around this in the Alzheimer's disease field about whether or not we should be ordering ApoE gene status on folks. The general recommendation is no, but that's not clinically indicated. We can talk a little bit later about it in terms of treatments, because there are treatments that are impacted by ApoE status, but generally clinically, it's not indicated to order that. And then most of the risk factors for stroke also apply to Alzheimer's disease. So cardiovascular health, all of those apply to AD as well. So cognitive presentation of a typical Alzheimer's disease patient, and I highlight typical there because, again, there are very heterogeneous presentations, but what we often think about is early memory problems, so repetition of information, misplacing items, struggling to recall details of conversations. Oftentimes, there'll be some navigational difficulties, like maybe taking less efficient routes when driving, sometimes getting frankly lost, but usually not in the early stages, and some organizational difficulties. Again, classic presentation of Alzheimer's disease. So with that, I always like to talk about why should we care then about correctly diagnosing Alzheimer's disease? I think this is a really, for me, something I'm very passionate about, and it's helpful for me to hear from different perspectives what challenges people are facing with diagnosis. And so when I think about why we should care, I think first and foremost right now, what's coming to top of mind is that there are now anti-amyloid treatments for Alzheimer's disease. Since 2023, we've seen the advent of some of these treatments. Happy to talk about that more. Dr. Tara Carlisle oversees a clinic for AD-related treatments. And so that's been an exciting, controversial, challenging new era of working with patients with Alzheimer's disease, but it is something that should be known, that there are treatments now available. There's something very clearly potentially actionable. And as you can imagine, the reason that that would be actionable is that you actually need to have evidence of Alzheimer's disease to receive these treatments. And that's where we'll talk about biomarkers some. Correct diagnosis of Alzheimer's disease can also minimize unnecessary healthcare utilization. And this has been shown in several studies that misdiagnosis or underdiagnosis can lead to delays in care, inappropriate administration of some therapies, but it's not always even about therapy. I think when there is a misdiagnosis or underdiagnosis, it leaves less time for care planning for a family, which I think is increasingly people are more aware of. There's also data to suggest that lack of diagnosis or misdiagnosis can also impact aspects of mental health for both the patient and the care family. Another reason I think it's very important to focus on correct diagnosis is that the patient's symptoms may be due to a non-degenerative cause. So something that's very addressable through lab work, looking at things like untreated sleep apnea. Or it could be due to a different neurodegenerative disease that will have a different course. And again, I think that for me, that's very important to think about, that these different neurodegenerative diseases, and I know it is overwhelming. There are so many, and I'm about to show you some more that are going to make that feel even more complicated. But they have different courses. And so establishing prognostic guidelines for that patient and that family changes depending on the etiology of the presentation. And finally, a lot of patients and families often want to know the diagnosis. And there's been great work showing that these patients and families actually do alter their future planning based on diagnosis. Okay, so why is it important to discuss typical AD? And I hear this across the board. So primary, secondary, dementia specialists, why is it important to talk about this, discuss this? And I think that this has been challenging for all of us to think through. So we know that misdiagnosis and underdiagnosis rates are high. And there have been really wide ranges depending on whether or not they are population-based studies versus in clinic studies, but they are high. They are also high in subspecialty clinics. And so when you think about dementia specialty, where this is their bread and butter, we are seeing 25 to 30% misdiagnosed. And this is based on clinical assessment, not using biomarkers. I think something that really propelled the field forward towards this biomarker approach that I promise I will get to is that in some of the clinical trials, some of those spectacular failures that we saw with clinical trials of Alzheimer's disease, and there are many, in some of those trials, when they went back and they had a sub-study where they looked at biomarkers of Alzheimer's disease, they discovered that more than 20% of those folks enrolled in the clinical trials did not have Alzheimer's disease. And so you can imagine it is very tough to test a drug if you don't have target engagement, right? And so you need to make sure that the person has Alzheimer's disease to test whether a drug is effective. And so in the neurology field, those results were staggering, they were startling, really made us think about, well, maybe we are also not as good as we think we are at clinically diagnosing Alzheimer's disease. And what do we need to do to increase confidence so that we can actually test drugs and help with prognostication? So before again getting to those biomarkers, I think broadly, what are these clinical diagnostic pitfalls to look out for with Alzheimer's disease? I think one, memory problems are not specific to Alzheimer's disease. They can be seen in other brain pathologies. Memory problems are also not always sensitive to Alzheimer's disease. We already saw someone with visual spatial problems that we talked about. Third, co-pathology is very, very common. I think for a long time, I think particularly when I was in graduate school too, there was a lot of focus on vascular dementia being a primary cause of cognitive impairment. And what we've seen over time based on autopsy studies and in vivo biomarker studies is that it actually rarely occurs without Alzheimer's disease. So only about 5 to 10% of patients who have vascular dementia have it as a sole cause. So it's usually moving in tandem with Alzheimer's disease, which again affects the course. You're going to start seeing more memory problems that need to be addressed. And finally, as we've mentioned before, there are non-degenerative causes of memory problems as well. Low B12, untreated sleep apnea. There are several things there that are very addressable. Okay, and this was just in the most recent Alzheimer's Association facts and figures. There are numerous pathological causes of cognitive impairment in late life. So we often think about Alzheimer's disease and cerebral vascular disease. I'm not going to get into these others, but ones that can often look like Alzheimer's disease in terms of memory problems include this hippocampal sclerosis. Something not included here is called late limbic associated TDP-43 encephalopathy. The reason that is relevant and A is for treatments, that if the patient has memory problems and has those and does not have Alzheimer's disease, they're probably not going to be responsive to an Alzheimer's disease treatment. And the second is the course is a little bit different. Late and hippocampal sclerosis are much more common in people in their 80s and 90s, much slower course than typical Alzheimer's disease. So it just doesn't move as quickly, which, again, affects future planning. This is just to outline, again, this is the slide that I think is overwhelming for any of us diagnosticians of how are we going to get to the bottom of this, but just to know that there are other causes of cognitive impairment and other causes of memory problems. All right. And so with that, now we are on to the biomarker piece of it. So in 2018, the field, the Alzheimer's disease field, they released this research classification for diagnosing Alzheimer's disease. And this was research only, so not considered to be appropriate for clinical use, but it really set the stage for where we are at now with the most recent ones. So with this really focuses on two proteins that we know are highly involved in Alzheimer's disease pathogenesis, which is amyloid and tau pathology. I am not here to tell you that that's the cause of Alzheimer's disease or to get into that debate. I will tell you that they are very, very tightly connected to it. And so um, autopsy studies of Alzheimer's disease are very focused on amyloid and tau conformation in a patient with AD. Neurodegeneration is just referring to what we see on a brain MRI where you have atrophy in specific regions. And so this was sort of the continuum framework of Alzheimer's disease that was introduced. What was very striking about this and what has been so controversial is that this framework established that biomarkers were needed in some way to determine that someone had Alzheimer's disease, and that it was defined by pathology, by etiology, and not symptoms. And so with that 2018 framework, this is the criteria that unleashed a storm of controversy, was that the term Alzheimer's disease refers to an aggregate of neuropath changes and thus is defined in vivo by biomarkers and by postmortem examination, not by clinical symptoms. When I say that there were meltdowns in the field, I am I am not exaggerating, in the neurology field. So very controversial because, as you can imagine, what this means is that you can be asymptomatic and be considered to have Alzheimer's disease, correct? I'm going to again hold off on that to the end because I don't think it's especially clinically relevant right now. What is relevant, I think, to clinical work right now is the idea that if you do have symptoms, that testing for a biomarker is starting to become more of a norm in the neurology field to confirm Alzheimer's disease for all the reasons that I had mentioned before, the misdiagnosis rates, the mimics of AD. So what are these biomarkers? So in symptomatic individuals, we know that if they undergo a PET scan, that you can actually visualize whether or not they have amyloid in the brain. So these are examples of PET scans in folks with MCI due to Alzheimer's disease and dementia due to Alzheimer's disease. So this was what was based for the regulatory approval of amyloid PET. And in that study in particular, they had people who had underwent a PET scan 1 year prior to death, at least. And so very, very close to autopsy, they had a PET scan where they could look at the association between them. And they were excellent. I mean, the sensitivity of these amyloid PET scans were 96%, specificity 100%. Again, very tied to people who had it in close proximity to death, so more severe staging. But in general, amyloid PET is very, very sensitive to the pathology. Similarly, we have also seen really increased uptake use of CSF markers, so cerebral spinal fluid markers of AD neuropathology. I can go into as much detail as you want at the end if you have questions about this, but just to kind of highlight some of the ratios that have been used, they are a tau to amyloid ratio or different forms of amyloid ratios. And again, they work very well. The regulatory approval of these assays were benchmarked to the PET imaging, so they were not initially benchmarked to autopsy. However, when you look at how well they perform against autopsy, it is also very good. So we're talking about 88 to 93% in terms of accuracy rates against that. All right. So with that, taking a brief pause there, these guidelines, again, have been studied quite a bit at this point. So that was 6 years ago. I think a lot of the questions that often come up to me is, okay, so it's associated with pathology. Is it clinically meaningful? There's been tremendous amount of work to show that if you have someone with MCI level of severity and they are amyloid positive, they will progress at a far greater rate than someone who is MCI who is amyloid negative. Again, the idea being that AD is a progressive etiology. It doesn't mean that people who are amyloid negative won't progress, because they could have another progressive etiology, but they also might not. And so the rates have been variable in what have been reported, but the hazard ratios have been about 3 in terms of comparing amyloid positive to negative progression over just 2 to 3 years. And so it is clinically meaningful in terms of you see more rapid decline in people who are biomarker positive for AD. Okay, so from that, we are now moving to 2024, and the guidelines that just came out this summer are an extension of the 2018, but they are now considered a bridge to clinical work. And so big question about what that means. I know we all get excited about frameworks that don't give clear clinical guidelines. I know that I do. So with this, again, what is the controversy here? They say Alzheimer's disease is defined by biology, is an etiology separated from symptoms, and can be established with a single core biomarker. Those biomarkers that we were discussing before, spinal fluid, PET. As we all know, those are difficult to access. Those are usually specialty clinics, and not all specialty clinics. There were a very long time where we did not have access to amyloid PET here. Certainly don't have access to tau PET or some of the others. And so I think there's previously been this hold in terms of how it affects other disciplines besides neurology or outside of neurology, because it has been more challenging, more specialized diagnostic workups that would be needed. That's changing, and that's changing very rapidly. You know, I think it's been very rare in the history of research with Alzheimer's disease that something has changed so rapidly. And I would say that the biomarker piece is absolutely the one that has changed the fastest. So blood biomarkers previously were not that great in terms of identifying Alzheimer's disease. There have been some that have been available that you know, are easy-ish to order, that are not that sensitive or specific. In the last year, and I would say even in the last 6 months, what we have seen is that there is a plasma, so a blood version of a tau marker that has excellent sensitivity and specificity in terms of predicting pathology. So benchmarking against amyloid PET again. These indicators have very strong positive and negative predictive values. Again, when you're talking about those types of values, they are age-related. People in their 50s and 60s, it's a little bit lower than if you're in your 80s, but they are very, very high. So just to give you an example of a study that just came out, in patients with mild cognitive impairment, age 80 plus, which is, I think, you know, representative of a lot of patients that you all probably see, or just in patients with clinically diagnosed AD dementia, the plasma p-tau217 can rule in amyloid pathology with the positive predictive values of greater than 90%. Similar in terms of ruling out AD pathology when you have an atypical presentation that you don't think is AD and you just want to rule it out. On the right there, I know that's a little bit fuzzy. The paper just came out, and so this was actually from a news site called Alz Forum, which is excellent, for the Alzheimer's conference that occurred at the end of July. And just walking you through it, the blood biomarkers at the top, the CSF are at the bottom. That p-tau 217 that I just mentioned, about 0.93 in terms of accuracy compared to PET, doing as good, slightly better than even some of the CSF markers. We'll see how that shakes out, but it looks excellent. It looks very, very comparable to CSF. And before we get into even more of the controversies of implementing that, being in the field for so long, it's exciting to me to see or to think about the idea that we could have something that could be so much more accessible to people who live in rural areas, who have minimal access to academic medical centers, to finally have something that's not so sequestered to specific knowledge bases. There are issues, and I will talk about those too. This paper just came out. I think I saw some of this was circulated throughout the university as well. One of the big questions has really been, okay, so this marker, it works well in your really highly characterized cohorts that don't look anything like my patient that I see in clinic. So this paper was focused on primary and secondary care and how well these work. So they took a very large sample of patients. They established what those cut points for positivity and negativity would be, and then they applied it to primary care and they looked at secondary care. As you can imagine, the demographics of those cohorts were very, very different from each other in terms of cardiovascular risk factors, just the multiple comorbidities that were going on in primary care versus dementia specialty. It performed very well, meaning they were able somehow, this is done in Europe, to have all of these patients have a spinal tap in addition to the blood marker to see how well it performed. It did very, very well in primary care. Did very well in dementia subspecialty as well. I think impressively too, similar to what we were talking about before, if you look at the clinical diagnosis compared to how well the biomarkers perform, so clinical diagnosis of do you think this is Alzheimer's disease versus how well the biomarkers performed. Biomarkers performed better than the dementia specialist in terms of using clinical guidelines and perform better than primary care in terms of predicting AD. Primary care physician, sorry. And so these initial results, I think, have been good. They've been exciting to see that they are predictive of disease, not just in a very specialized research cohort with 7,000 exclusion criteria, right? Okay, so the future. And again, I want to highlight the future. This is not right now. How could blood biomarkers contribute to an evaluation of a patient with cognitive concerns? So what could they do? They could provide biological evidence for or against the presence of AD neuropathology. So if that's a question mark in the diagnostic workup, they could potentially do that for you. They could also help triage patients to be evaluated for anti-amyloid therapies. A patient's not going to get an anti-amyloid therapy without some sort of biomarker, and this could be an early way of triaging a patient towards that. What can't they do? They can't determine whether AD is the main cause of the patient's symptoms. So we were talking a little bit before that you can have a lot going on with these patients. Dementia with Lewy bodies, 50% of those patients also have Alzheimer's disease. So if you have a patient coming in and they are reporting hallucinations that are very concerning to them and their family, very possible that they also have Alzheimer's disease, which is contributory, but probably not the cause of those hallucinations. And so it can't tell you if it is the main contributor to their cognitive problem. I like to think about it as the young kids say today, is it in the room with us? AD is in the room with us if it's positive. It doesn't mean that it's the main contributor, though. It could be. It also can't replace a clinical workup because of that. I think over time, it'll make it faster, more efficient, less retesting of things, but it can't replace doing that initial discussion with the patient, initial screening, because you still have to think through, okay, do they have low B12? Do they have untreated sleep apnea? All these things that can affect their thinking and quality of life. And currently, it also can't clarify the severity. So you're not going to get a biomarker back that says they have mild cognitive impairment, right? It's a disease biomarker, not severity or syndrome biomarker. So that's what it can't do. So I would sort of conceptualize it as something that could complement, hopefully make things more efficient, but cannot replace that clinical workup. So this is from a paper that just came out by Michelle Milkey, who's very, very involved in this space. Again, the future. What could triaging for anti-amyloid therapies look like in primary care? And what they have established there is that you would do the initial medical exam, exactly what I mentioned, that initial workup to rule out other things that are contributing. At that point, if the question is, we think that this might be Alzheimer's disease, could order a confirmatory biomarker at that point. You get the results back, you discuss it with the patient, and then you make a joint decision, a shared decision as to whether or not you would want them to see a dementia specialist for additional workup or treatment, or if you stop there. If they were sent to a dementia specialist, the idea then would be whether or not they would be getting an anti-amyloid treatment. Currently, they have this additional confirmatory test. I think with these new blood biomarkers, that will probably over time be eliminated, and they will be tested for all the other things that are necessary to proceed with an anti-amyloid treatment. But again, it could stop at that course right there after obtaining the biomarker if the person does not want treatment. Again, this is the future. I want to be very clear that this is not right now. This is not a suggestion at all to be ordering right now. I just want to give you that what's on the horizon, that the train is coming, and this is something that we should be thinking about. So what are these additional caveats for blood-based biomarkers of clinical AD? As you probably have guessed, it's been tested primarily in people who are white. That is changing. There are more studies being done now. There were just really great studies that were discussed at our Alzheimer's conference in July with more diverse cohorts. I think along with that, thinking about differential risk factors in populations, there are some question marks and concerns about comorbidities and how they affect a blood protein level interpretation. So chronic kidney disease is something that's a concern in terms of how it will affect the absolute values that we get. I think that over time, it's going to be resolved with these hybrids, these hybrid ratios where they measure two proteins and the ratio is what's important. And so the absolute levels and how they're affected by more peripheral diseases will be less impactful, but it's a TBD. There's a great network that's been established called ADAC, where their entire focus is understanding AD biomarkers in aging adults with chronic comorbid conditions. So I think we'll be getting information on that soon. Okay, I wanted to wrap up. I know I'm at the very, very end here, but just saying that you all have probably heard a bit about or have been concerned possibly about what does this mean for asymptomatic people? And I think it's a reasonable concern. With a biological definition of disease, I think there's ethical, practical questions about what this means for people who are biomarker positive who do not have symptoms. So what I did not get into is that Alzheimer's disease starts at least 20 years prior to symptom onset. Doesn't mean you're biomarker positive 20 years before. It just means that the pathological changes are happening in community dwelling people. So about 20 to 30% of people in their 70s who have no symptoms are biomarker positive. And we don't think that it's benign, meaning that it is a risk factor for symptom onset. And you can see that here where they say, I think this is a very stark statement, controversial, but they say unimpaired individuals with abnormal biomarker test results are at risk for symptoms due to AD. They are not at risk for a disease they already have. I mean, they're going for it. So controversial. I mean, I think there are a lot of questions. To me, the biggest questions that come up there in terms of symptom onset is for folks that are in their late 80s, late 90s, those rates are higher. There's the Clifford Jack who wrote the paper. I think their perspective is if you live long enough at that point, you will develop symptoms of Alzheimer's disease. I think from a practical perspective, the idea that or the likelihood that you will be affected by some other condition that's more proximal to that is higher. So there would be a lot of, I think, discussion around that. But I think it is relevant in that the space is changing, and I would suspect in the next 5 years that we may be seeing more of this with asymptomatic folks. I'm on a national work group right now where the focus is on research disclosure to asymptomatic adults. Again, it's very controversial even in the neurology field, but trying to think through ways of how do we ethically, thoughtfully discuss risk in individuals who have evidence of Alzheimer's disease in the brain but are not showing symptoms. Um, I want to say that there is no indication at all clinically to order a biomarker for an asymptomatic person. There is no indication for it. None of the treatments can be given to an asymptomatic person. But again, I think these direct-to-consumer options, I think, are coming. And you may have someone come into your office saying, I found out I'm biomarker positive for Alzheimer's disease. I don't have any symptoms. And just being familiar and aware that this is occurring. There's a lot of research on this and starting to be able to develop discussions around what is risk and what does that mean. That's something that I'm very passionate about, that I'm working on, thinking through how do we disseminate that kind of information, because risk is very complicated to discuss. And we don't currently have something where we can say, okay, you're asymptomatic, biomarker positive, here's your exact likelihood based on these collection of health history factors for developing symptoms in the next 3 years. We certainly have a lot of research on it, but it's not population-based at this point. Okay, what can be done right now in primary care? I think asking patients if they've noticed changes in their memory or thinking, their subjective cognitive experience can be very helpful. Considering administering a screener like a MoCA or a T-MoCA, I know that is time consuming, so it may not be a possibility, but that's something you could consider, or a screen of daily functioning. And having those workups where you're looking at all those other contributors to cognitive impairment that can be very, very meaningful to a patient's functioning. And then keeping in mind right now that memory problems aren't always due to AD. AD can manifest with non-memory problems. There's different diseases that have different symptom courses, different prognostic outcomes, and that anti-amyloid treatments are available. I think that's the right now space. The other pieces are the future space that I think we need to work on and think about how to incorporate over time. And so I want to leave you with this last slide that I know this is a lot of information. It's a lot for all of us to take in. It's very challenging. And I think there's so many pain points here, so many things that make this diagnostically challenging. This was a figure from a paper that also came out not too long ago in 2022 about what are all the factors that impact challenges with diagnosis, the time limits, the resources, these AD mimics, so all this heterogeneity, inefficient screenings, all of that really are impactful. And I think these are areas for partnership. I certainly would love to be partnering with you all on these topics, the ideas of education, interdisciplinary consultations, interdisciplinary feedback, bi-directional feedback on how this is working. And so I really want to present that to you as an area for partnership that I think could be really fruitful, that I'm really excited about. Dr. Lum and I recently submitted, along with many folks from geriatrics and neurology, a grant with the idea being to really develop infrastructure around biomarkers in primary care and how to support you as clinicians. And so I am very open. I can take it. You can tell me what you think. And just really want to see it as a fruitful partnership and collaboration. So thank you so much. I know I went slightly over time.
Presentation. Thank you. We have 10 minutes for questions. I think this mic will come on. It seems like it's coming on.
Great. I think this is a great talk. I guess my question is that if a third of older adults or a third of people over age 65 have MCI or dementia, and half of those have Alzheimer's disease, and there's very few dementia specialists in the world, um, like how are we going to be able to implement something like this that I assume is pretty expensive? Um, and there won't be a lot of people to really understand how to interpret them. And how do we do that equitably since it's probably only like primarily rich white people that will get this? And so, you know, like if we're doing it because there's now treatments, the treatments are not available to most people, like both in terms of the world, like spatially, but also in terms of like the ability to be able to come in for that many appointments is a privilege most patients don't have. And so I think this is really cool, and I can't seem to imagine how we do this actually in real life.
Yeah, that's a great, absolutely multiple great points. So, um, again, kind of hitting on those points that are up there, the time, the resources, the expense, all of that. I don't know if I'm going to have exceptionally satisfying answers for you, except to say that I think that that's correct. I think that I think the hope, so it depends on how cynical maybe we are about whether this will actually happen, but I think the hope is that the cost of a blood test is going to go down quite a bit over time. I think a lot of people are viewing it like at some point in the future, not now, that this will be something that you can order with a workup that you're doing that says straightforward blood test. To your point, though, the question would be, what about the time for counseling? What about the time for interpreting the information that they're getting back? My hope is that what we are seeing is that we're going to have people building some of these templates, educational resources, trying to provide that support so that when you get a test result back, it'll kind of populate what does this all mean for that specific person in terms of risk stratification to help you with that. That's not happening now. But that is the hope. And really what we want to see is that it'll be cheaper over time, that it could be a straightforward blood draw, that it'll populate out with some templates of how to counsel and how to interpret the results and something to give to the patient. And there's actually already materials that have been developed at this point for patients that are looking much better, that are not as jargony, like that are actually thoughtfully being developed, that could be given to the patient. So it's not going to answer all of those questions, but I think that there are ways that we can start to address this over time.
Yeah, I appreciate, and I'm going to link to Abby Robiecki's question in the chat. So as a social worker and researcher focused on symptom management and caregiver distress, could you say more, I think, about how the emerging diagnostic tests for AD may address the significant distress experienced by caregivers surrounding diagnosis, where they may want or need a definitive diagnosis? And so you're speaking of some of those counseling materials. Can you say a bit more about what you know is currently being studied and any findings related to the caregiver distress?
Yeah, that's a great point. I don't actually know as much about how the biomarker disclosure with blood biomarkers, something that'll be more efficient, is impacting caregivers. I know that there have been studies that I mentioned before of that uncertainty around diagnosis, particularly when you know and are seeing changes in your loved one that are very upsetting. There can be a sense of relief to not feel like you're continually searching for an answer to that, to the caregivers. I think the materials piece, though, those are, I know, being developed at this point for both patient and care partner to better understand risk. Just kind of adjacent to that, I think another question related to that is often how well people will take it. In research, at least, patients and their families seem to be, if you do some brief counseling ahead of time, which I know is a time constraint, that they seem to handle the information well, that we don't see significant increases in depressed mood based on a positive result.
I'm curious. I'm curious if there's any interface between genetic counseling and this topic, because it seems very similar in terms of like our potential risk, our future concern for a disease. And I think our genetic counselors are actually very knowledgeable in trying to counsel patients and families. And it would be interesting, not that it's necessarily genetic related, but I think they have a lot of tools that could potentially help our systems. Is that being considered, or is there any collaboration there?
Yeah, I love this idea. So at the last work group that I was on around risk education, we had two genetic counselors on the call, and we talked through exactly that topic of, even though this is not necessarily a gene-related discussion, the complicated and nuanced topic of future-oriented risk is something they're very familiar with, and how do we leverage that existing knowledge to apply to this? And there was a lot of enthusiasm from the genetic counselors around that topic, that they absolutely have knowledge to give to that. So I think that will be an important space to watch.
Hi, thanks for this talk. I'm curious to know what you think, or what the shape of the collaboration is between neurology and geriatrics in this area. I do know one of the challenges that I've observed is just that when you look at studies of oldest old, you have multi-neuropathology as well as multi-morbidity. And those patients never make it into trials for these drugs for obvious reasons. And I think that sets up just it's not really a conflict of interest, but not necessarily fully aligned interests between sort of geriatrics, who wants to care for these people regardless of what the outcome might be, and candidacy for therapy, versus neurology, which understandably wants to treat diseases earlier in course where that might be the dominant thing that makes someone's life worse. And so I was just curious to know what those discussions have been like in terms of how to broker that interface between neurology and geriatrics.
Yeah, there's a lot to unpack there. I would say in terms of, and I'm not sure what terminology you use in the geriatric space. In research, we refer to folks as the oldest old, who are 90 plus. So correct. The norm on autopsy for the oldest old is multiple pathologies. We're talking about 3+ pathologies. And so I've been interested in, I'm not sure disappointed is the right term, but a little confused about some of the guidelines coming out, that I have question marks around individuals who are 90 plus, not wanting to sound ageist in any way, but what is the impact of some of these tests when there are probably multiple competing health questions going on there that might take priority, and also the fact that there are multiple pathologies going on there. I think even in the oldest old, we've seen that it's not benign, but whether it's the most proximal concern at the time, I think is a bigger question. There is a really great study called the 90 plus study by Claudia Kawas, who's done a lot of work in this area. And so I'm not aware of the current conversations between neurology and geriatrics around the oldest old and how it will apply to these diagnostics. I know that the current guidelines don't have an upper age limit. They have a lower age limit, but not an upper age limit. But I think it's very well taken. I think it's been discussed in the past. I'm not sure what's happening in that space currently.
Bree, thank you so much. This is all very fascinating. And I have a number of questions that I think will come through in a case study from our couch last night. So I have a cousin visiting, and she said, I just got back from a visit with my mom. We took her to I don't know if it was a neurologist, but a specialist about her dementia. And she kept saying, why are you doing this? Why are you testing me for this? And your point about uncertainty is why she was there. It was clear her mom had dementia, but she needed to know, because she felt as a caregiver, she was doing something wrong, and she was frustrated with her mom. She's not trying hard enough. Why is she being so mean? And it suddenly made sense. Oh, it's the dementia that's causing these behaviors. And suddenly she has this huge sense of relief, because she has a reason for her mom's very frustrating behavior. So I think that speaks to the uncertainty in some of the diagnostic things. And I wanted to hear, what are you doing now in neuropsych clinic? Are you doing the biomarker testing? Because it seems like the specialists didn't do as well as the biomarkers. So how are you all handling that disconnect?
Yeah, so neuropsychology, we can't order any of those types of tests. So we're PhDs, not MDs. But I'm embedded in the neurology clinic. And so a lot of our patients and families are being referred to me who in tandem are getting these biomarker tests done. And so it's changed our role quite a bit too. I mean, I think there's been just a kind of a lot of existential fear in different areas of work too around what this means for what we can offer. And so I often talk with families, the patients and the care partners about after the doctor has told them the biomarker result, how we can think about some of the testing results in light of that, that they now know the cause of the disease and kind of talking through that. But how are we going to move forward with knowing that here's your mom or your dad's strengths right now. Let's capitalize on those. But with that, we know that they have Alzheimer's disease. So this is going to be progressive. So giving that prognostic piece of it too, I think using those in tandem to me has been very beneficial to the family because you can address some of that diagnostic uncertainty while still talking about what are some of the strengths that we're seeing that we could capitalize on and what are these safety areas that a biomarker test is not going to tell you, right? Like it's telling you disease, but not the staging. And so we're not ordering it, but we're incorporating it into those discussions.
Great. And then the very last part of that conversation was, so can I start the anti-amyloid? Because she said, well, don't they test because then you can get treatment? And I said, yes, but their treatments are pretty complicated right now. And she said, well, shouldn't I be getting it right now? Because I'm in my 60s and my mom has dementia. And I said, stay tuned.
It is a stay tuned.
Thank you so much. Really appreciate this.